Everyone. Thank you so much for being here. My name is Luis Martins here at the Metaverse webinar series at HealthTech Portugal to provide you with an insight on what is happening and how immersive tech is influencing healthcare, not just practitioners from the practitioner side, but also from the supplier, from the startup side. And today we have the pleasure of having Valentino Megale here with us. So Valentino is the CEO of Softcare Studios, sorry. But besides that, Valentino is also the partner in crime at XRSI-Europe, XR Safety Initiative Europe, uh, which is a standards development organization for privacy and safety in immersive worlds, which actually also connects with healthcare. And we'll be talking a bit about that. But for now, Softcare Studios is the focus. And for that, and for taking the time, thank you so much, Valentino, for being
Thanks
here.
a lot. Thanks a lot, Luis. Once again, thanks a lot also to HealthTech Portugal and to all the attendees today. So it's a pleasure to meet you virtually, remotely, but in presence right now in our common time. So thanks, Luis. I'm going to share my slides actually, because I want to start by sharing some material about what we are doing also at Softcare Studios, and not only us, but also what's happening in the field. Well, we are going to talk a little bit more about the virtual reality in the pain management field. And this is something that we should see. Because virtual reality is a technology that if you don't see that, just a word explanation is not enough to catch really the potentialities of a technology in which digital content becomes something that we feel and experience in first person. So visuals are a good starting point. Not enough, but a good starting point. So what about Softcare Studios? Briefly, my background as a professional is in neuropharmacology. So I really started my journey as a scientist, as a researcher, and I started my journey in the so-called wet lab. So in a very physical way of synthesizing drugs with a health potential in oncology and neuropharmacology. And 10 years ago, with my colleagues, biomedical engineers, software developers, and also business innovators, I decided to go on the other side of the bench, I would say. I decided to explore the opportunities of virtual reality as a digital technology to replace drugs. So this is an interesting digital extension of the work that I was doing, because the goal is the same. The goal is to provide health value, support the quality, also the outcomes for patients, but with a tool that is able to replace drugs and that is able to reduce the side effects of many drugs. Not every drug, of course, but specific categories of drugs. So with Softcare Studios, a company that if you want to scan the QR code there, I promise this is not phishing, it's not any kind of cyber attack. You can scan safely, you can go on our website. What we do, we use virtual reality for something that we call virtual sedation. So a replacement of the total sedation and also a replacement of painkillers in specific domains with virtual reality. And we also apply the same technology to support clinicians to learn, to increase the confidence and reinforce their skills in their traditional routine activities. The same tool can be deployed in the same hospital and can become a value for both, for patients and clinicians. So you see some of the images here. On top, you can see Tommy, which is our flagship, I would say, product since the beginning, since 2016, a project that we developed and distributed in hospitals. We are mainly active in Italy. We are in more than 20 hospitals in Italy. And we really started with pediatric oncology as a tool, in this case, the virtual reality, to go beyond the walls, because this is one of the most challenging aspects for especially pediatric oncology. The walls of the hospitals are for sure not the space where children want to stay. And virtual reality is not there to replace the the experience, unfortunately, the experience of oncology, but it's a way to go beyond the walls of the hospital and to empower again patients and to take the control in a very uncertain moment of their life. You can also spot other situations like one of our colleagues, Oliver Dada, who is developing virtual reality content for a rehabilitation process with a university in Italy. We just connected virtual reality with an exoskeleton in that case. And you can see an adult patient lying on the bed during a procedure that is actually a vascular access, a peak placement before a surgery. Anyway, we are going to see this more, and I'm moving on. Okay, perfect. Because we want to talk a little bit more about pain. And I want to start from a consideration. Pain is not just a feeling. It's not just a mechanical, I would say, a result of a harmful situation. We are hurted, we are harmed, and we perceive pain. Pain is much more. We can compare pain to a story, to a complex system of signs, depending on many multiple factors. So pain is the overall experience of pain. And part of the painful perception is also depending on the space where we are, on the experiences that we are doing before the painful procedure, for example, and after the painful procedure. So what I want to highlight in this moment is that traditionally, if we think pain is just a spot perception, that means that we would like to administer a painkiller or a sedative and remove the pain perception for a moment. But generally speaking, pain is more complex, and virtual reality can help us rewrite and change the entire context of pain without necessarily administering the painkiller or the sedative. We will see more about this in a while. But actually, pain as a process from the physiological point of view, it starts when something happens in our body. But at the end of the day, almost 60% of our final pain perception depends not on the harm and not on the severity of harm, but on the psychological condition of a person. Pain is actually the result of emotional states, of attention, how much focus we are dedicating to the painful perception, how much we are expecting from a specific situation. Imagine that maybe you experience something that was painful a lot, and the next time you are approaching the same procedure, you are expecting to feel pain again. So you are expecting pain before, and your pain threshold is reducing. And that means that the overall pain perception is going to increase a lot due to the anxiety and not actually to the real, I would say, objective, we can say objective, pain generation in that moment. It depends on the coping mechanism. What is the coping mechanism? When we are working with patients, the 60–70% of them, they try to look away from example, from a needle or from a medical procedure. This is something that is quite common. But there is still that 30–40% of people, when they are undergoing a medical procedure, they need to look at it. They want to have the control. So the coping mechanism is something that can facilitate, for example, the deployment of virtual reality or not. If we are providing a virtual reality and we are clashing with a coping mechanism, we are not providing support. We are just increasing the anxiety. So this is something that should be also considered. Of course, virtual reality is perfect for people who are looking away, because virtual reality is a great tool to look away much, much further than before. And of course, it depends also on social relationships and interpersonal connections. All of this contribute to the final value and the final perception of pain. So virtual reality actually is not a drug. It is not going to disable the receptors of pain. This is not going to reduce the release of pain messengers in our body. It's not going to block the signal transmission in our neural system. But virtual reality is going actually to act on the psychological parts of the pain that we said is contributing to almost 60% of the overall pain perception. So virtual reality is going to expose patients to a controlled set of sensory stimuli that are able to change the story of pain, to change the context of pain, and minimize, reduce the overall perception of pain to a degree where painkillers maybe are not needed anymore, to a degree when the sedation is not needed anymore, when pain can be managed by both patients and the clinician. So this is more or less what we are doing. And well, you can see also a short video of a patient, but this is just a preparatory moment of the procedure. What I want to say is that in the most of cases, when we are managing pain with patients, we require interaction. A drug is something passive. Okay, you take the pill and you just disappear. Your attention disappears, especially when it comes for the sedation. In this case, patients are not hypnotized, patients are not passive. They became an active part of the therapy. And one of the most, I would say, useful way to reduce the attention to pain is something that is called sensory motor distraction. A process in which you expose patients to sensory stimuli and you require in return a motor reaction that should be timely, that should be precise, coordinated. This reduces the cognitive load dedicated to pain and reposition, I would say, replace the pain perception with the perception of another context that is relaxing, that is engaging, that is stimulating. Well, generally speaking, the field in which we apply XR technologies in healthcare can be called embodied medicine, because it's a set of interventions in which the possibility to embody an avatar, a virtual one, in another space generates value to the therapeutic journey. Well, this is based on a foundational thing. When we expose people to sensory stimuli, we can use the stimuli to trigger behaviors and to trigger a process that is native to our brain, something that we call neuroplasticity. Our brain reacts to stimuli, rewires itself, and adapts to the world that is constantly changing. This is called neuroplasticity, and it's an amazing superpower that we have, for good and for bad, because of course neuroplasticity can also lead to rewiring that is not always healthy, but that can also it can also generate pathological conditions, especially when following trauma, for example, or chronic pain. But with virtual reality, we have the possibility to, I don't say exactly guide the neuroplasticity process, but we can influence this process, allowing people to get closer to a good health outcomes, to a positive health outcomes. So in virtual reality, what we can do is taking people, patients, in a virtual space and also allowing them to embody a virtual body. These are two elements that traditionally in our daily life cannot be changed so easily, but in virtual reality, we can do that with just, I would say, with one click. But this is a huge potential because we and our brain builds our behavior based on what we see outside and how we perceive ourselves. So by controlling space and body, we can actually influence also the pain perception. Well, body and what we perceive as body in VR is not neutral. This is something that, starting already from Jerome Lanier, the father of virtual reality, we saw. Jerome Lanier already in the 80s, 90s said, if I am in virtual reality, why to embody the good old body, human body? Why not to embody a squid? And by embodying a squid, Jerome Lanier discovers, and he started also a journey of discovery, something that can be called homuncular flexibility. Our cortex rewires and adapts to the body we see and to the body that we perceive as real. So it's not only about what we see, but how the sensory stimulation is provided to the final user. This can be used, for example, in the treatment of eating disorders to recalibrate and reduce the mismatch between what is our body and how we perceive our body, something that is at the core of anorexia and bulimia. But at the same time, space, the space we perceive, is a relief factor. Roger Ulrich already in the 80s was showing that patients that are staying in a physical space that is, well, humanized, is curated, is more human focused, they present faster recovery times in the hospital. There is a reduced pain medication use because they don't require so much painkillers. They perceive less pain, and they reduce also the stress hormones release. This is a direct, I would say, impact of the space that is surrounding patients. What about stimulating and simulating with VR additional spaces that can have a health impact on patients in the hospital? This is actually the great quest and the challenge of VR. So this is not a new kind of topic. This really started back in the 90s with Hoffman and Peterson, that with Snowworth show that when patients are undergoing a VR experience, the pain areas in the brain, as you can see also from the MRI scans here in the image, the pain processing areas in the brain, they reduce their activity. This is much more than distraction. Our brain on VR works differently because there is a split in the sensory stimulation. What we perceive with vision and listening, it's separated from what we perceive with haptics. This kind of mismatch generates a state that is suitable for drug-free pain management with VR. And from that moment, many companies, also Softcare included, they are working to just optimize, adapt this kind of native effect on VR on the brain based on the specific context and medical treatment. This is what we are doing with Softcare Studios, with pediatrics, with adult patients, with elder patients. So we are designing virtual spaces that are able to have a real impact helping patients, but also facilitating the life of the clinical staff. One of the like we started with pediatric oncology, but during the pandemic, we have been contacted by several hospitals in northern Italy, first of all in Milan, and also by Dr. Januario Sanna, who were looking for an alternative, drug-free alternative to manage especially pediatric patients during the vascular access routine. So PIC, CHIC, and similar. Because in the most of cases, in many cases, like in 60% of cases, children, they need to be totally sedated. Vascular access is an invasive procedure. It's, I would say, painful, but also stressing as a procedure. And except for the local sedation with lidocaine, what clinicians need is to totally sedate patients to safely complete and successfully complete the treatment. But this looks like a simple thing, like you put asleep the patients immediately, but they also can present side effects. And side effects can have been documented widely in the population of pediatric patients undergoing total sedation. The surgery room that you need to use to position the PIC or anyway to complete the vascular access has a cost. Like in Italy, an hour cost of a surgery room is 800 euros, for example, per hour. Then, of course, you need to involve the anesthesiologist, and you need to wake up the patients. And the wake-up process can be also stressing and can be also quite complicated sometimes. It's not standard. So all of these challenges are related by the fact that so far we try to manage the complex and critical behavior of patients with a drug. But what we are doing is providing and exposing patients during the procedure to a virtual reality content and experience that has been designed to fit in the, I would say, expectations of the age group of patients, fit in the specific medical procedure in terms of timing, and ensure also that the physician and the nurses can complete safely the medical treatment. So by scanning the QR code, you can see one of the feasibility studies that we did at the Buzzi Hospital in Milan. And this is just a short video just to show you what is happening in that case. This is the beginning of the vascular access positioning. They're just trying to find the position where to insert the peripheral catheter. But the most important thing here is that we are providing a rhythm and music, I would say, experience in VR, which is a sensory motor distraction. So senses that require a specific timely motor activity. but half of the patients is blocked and half of the patients is free. So we make value of the half patients free, so the hand free, and we engage, you involve patients in a game, which is of course visual, it's also audio, and the patients can stay like this for up to 1 hour and something. So we set up the timing to 2 hours, but not because 2 hours is the length of the treatment, but because there could be many delays. So we don't want the game and the experience to stop in the middle of the treatment and the patient saying, hey, what's happening? Well, what I need to do. So we want to generate a flow condition with a game that is changing also in time, that is changing the sound, that is changing also the criticality and also the difficulty. And the patients enter in a flow situation when at the end, you just need to say, hey, we ended. So you can wear off the headset and you are free to go out. No awake, no side effects, no actually also logistical problems. I just want to make an example. We are working with many hospitals, and one of the hospitals we are working with is in Sardinia. And they have a lot of problems because they don't have always available anesthesiologists. So sometimes when they need to do a treatment like this and they don't have the anesthesiologist, they say, I'm sorry, we are sorry, but your family and the child, you need to take the flight to Genova, which is another, I would say, mainland city compared to Sardinia. And you need to go there because we don't have the anesthesiologist. So it's a great challenge for the family and for the child. With the virtual reality, what they are doing is they are avoiding to need, I would say, the anesthesiology is on place. They can perform the treatment in place with a child, reducing the side effects. We did the feasibility study. What we saw is that we have, just generally speaking, a significant reduction in the anxiety level before and after the treatment, and very slight, very limited increase in pain perception, because we should remember that before and after they underwent a treatment. So of course, after they wear off the headset, they will have a part of the body that is still affected by the positioning of PICC, which is the catheter stays inside of the body, and this will be used for the administration of drugs in the next months, for example, in the next weeks. But the general level of the appreciation by the patients was very high, and not only by the patients, but also by caregivers, because they see that their child has not to undergo actually sedation, that is seen by many, of course, caregivers, by many parents as something risky. I just want to highlight this. On 10 people, on 10 patients in the feasibility, we just had 1 patient that refused the treatment, and there is a reason. There is a reason connected with the challenge that I'm going to say later. The nurses positioned a headset that was switched off. So from that moment, we needed always to explain to nurses that you need to switch on the headset. That is not a bent, that is not something that is just passive, but it's a window to another world. It's a window to engage, not to put asleep the person. So this is important. Well, we are now doing other studies. We are just finalizing the analysis of data of a multi-center study that is sponsored by Becton Dixon, a medtech company. We can also be incited by a review about the field as 2 companies doing virtual sedation in the world, and super happy because inside of the reviewers, there is also Hunter Hoffman, who was I would say, the pioneer in the sector. And we are studying right now what is also the gain, the economical gain for the hospital. Because as I said, there are costs related to sedation. There are also logistical. We are just removing those costs and providing those bundles at a fraction of the total cost. So far, what we are seeing is that a traditional hospital doing vascular access to pediatrics between 8 and 13 years old, thanks to systems like ours, is saving up to 200,000 euros per year. This is just a niche. This is just an initial study. So of course, we need to validate more and more and more, the more we are expanding our activities in the hospital. We are now also working with adults and elders. And in this case, this is not a vascular access. This is actually invasive surgery. In this case, the patient is completely lying, and we allow patients to see and interact with the content also when they are lying. We also have content that is, I would say, not interactive. And that was an amazing challenge, because how to keep engaged and motivated person without interaction. So we need to play a lot with sensory stimulation, with their variability, also partially with storytelling and with voices, with audio. But on the other side, the patient has local regional sedation. So the regional sedation is always there, but many adult patients want to be totally sedated for comfort, but they cannot. They cannot because they have hypersensibility, they have vulnerability. So for them, virtual reality can be a great way to avoid the total sedation. A big problem is, of course, the nurse and a challenge, I would say, and also an opportunity. Nurses needs to be trained. Nurses, they are sign manager. If pain is a system of signs, the nurse is the one who understands who is the patient, what is the setting, what is the specific need and the perception and the expectation of the patients when it comes to the medical procedure. But they need to be trained to that. They are not trained exactly to do this at a daily basis. So if virtual reality is an experiential treatment, they need to understand how that experience, the virtual one, can fit in exactly that patient in that medical procedure. Otherwise, they risk to put on the head of the patients a switched off headset. So they need to be trained from the basics, what it is virtual reality, how to be used safely, how to evaluate patients, for the fitness in using this kind of device. They play an essential role, but there is a huge effort in training them from the beginnings, and this is something that we are investing a lot in the hospitals. Just to expand a little bit the context before closing, virtual reality for pain management can be used in a great variety of fields. So we focus on vascular access, we focus on surgery, but there are so many other fields such as dentistry, for example. And there is an increased use in dentistry for pain management, but also for anxiety management, because anxiety and pain, they are strictly related. The final perception is really dependent from both. And I like also to share this paper about the use of virtual reality in the pre-intervention of patients, especially in oncology. VR is actually an empowerment tool. It should not be seen and should not be, I would say, marketed as a tool that is eluding people, that is isolating people in another place. We are just leveraging our native imagination. That is an amazing tool, an amazing superpower to cope with pain. But in the hospital and with the stress of disease, the superpower can be deeply compromised. So virtual reality is about being used as a sort of a cognitive processes that we can use to remember that we have the imagination, that we can use to reduce the psychological aspects of pain. So it should be seen as an empowering, extending tool, and not something that is going to replace, for example, the role of patients. And of course, there is not only procedural pain, because we are managing procedural pain, but there is also chronic pain. There is much, much different also, and it's great variable across the population. I want just to share this product actually. It's called Reliever X. It's available in the US. It's actually a virtual reality content under prescription that is prescribed to people with chronic back pain resistant to drugs. It's a very defined niche of people who, because of the chronic back pain, they are, well, not exactly autonomous, or this can disrupt their life. So in this case, virtual reality is provided as a program, not as a touch point experience, but something that should be, in this case, should be experienced 10 minutes per day for 8 weeks in a row. And this is basically cognitive behavioral therapy that was converted in virtual reality. At the end of the day, this has been approved also by the FDA. Virtual reality is able to rewire and change the overall perception of pain of the person, and is able to provide autonomy again to the initial patients. Luis was also talking about the XRSI at the beginning, and I want to remember that virtual reality is a powerful technology, It can influence our brain for good and for bad. It can collect meaningful data. Because of this, it's an amazing opportunity for patients and clinicians to the extent we are able to identify the potential risks and I would say embed safety by design in those systems and those interventions. This is why in the XRSI, the global XRSI, we have a program which is called Medical XRSI. So a group of people working in the field that are trying to identify those risks. They're trying to simplify the understanding of those risks so that policymakers, patients, physicians, they can make better informed decisions when using this kind of solutions. This is Medical XRSI, and you can reach also the page and see more about this kind of content. They, of course, stress, and this is fundamental, that there is no one solution that fits all. That virtual reality is we should decouple VR as a headset and VR as a software. The headset is just a different computer, we can say, but it's the software that provides a very specific kind of experience. And this experience should be, I would say, contextualized in a specific, I would say, therapeutic settings, in a specific medical procedure, in a specific age group of patients. So there are many elements that should be considered when you are crafting the content to support patients and clinicians. So you need a framework to really simplify this complexity and to guide your decisions. And just last one, I want also to share also the connections with the XRSI-Europe, which is exactly, I would say, the extension and the European iteration of the global XRSI to the European context. So we are collaborating also with the European Commission and the policymakers to inform all of them about the different kind of challenges and risk of VR, not only in healthcare, but in the general domain. So here you can find also my personal contacts, and I'm also happy to share with you this book that was published like 1 month ago, edited by amazing Jessica Stone, who is a psychologist from Colorado in the US. But in this book, you can find so many specialists talking about the impact of VR in mental health. And I also curated the chapter dedicated to pediatrics and also to pain management. So hopefully it can be a great resource for all of you. Thanks a lot. Thanks a lot, Luis, and all of you. Hopefully, yeah, the timing looks good.
Absolutely. Thank you so much, Valentino. It was great to realize how impactful the VR can be, not just for the neural pain treatment, but also on the patient side, on the patient's experience, and also for business sustainability, as you showed. Well, I would start by asking you, can you guide us from your experience with interacting with hospitals? Can you please guide us a bit on your process when you are entering a hospital that usually does not have much familiarity with these technologies? How do you address and how do you move forward into actually making these programs reality?
Yeah, well, we make our products, but also we collaborate actively with pharma companies, for example. For pharma companies, virtual reality and digital technologies are a great way to position themselves on the market and to explore the wider topic of patients' experience. And just want to say that one of the pharma companies that we collaborate with, they are using a hashtag online that is Beyond the Pill. And Beyond the Pill, used by a pharma company, tells us a big and rich story. So, for example, if we work with these companies, working with big pharma and also with medtech is an amazing point, because they provide us a very clear understanding of the problem. So we started, for example, working with patients with sickle cell disease, which is a rare blood disease. And this kind of condition is always connected and associated with a pain crisis. So pain crisis related to the disease itself, okay, not the treatment. These people, they undergo blood transfusion every 2 weeks, forever, basically for the entire life. So every 2 weeks, they need to go to the clinic. They need to undergo like 1 hour of blood transfusion in spaces that are not always the good one. They are not so well informed about the treatment. and they also feel pain in very specific moments. So we have been contacted by, for example, by this company, and we always start with the deep need assessment. Who is our patient? What are the emotional constraints, the physical constraints, the psychological constraints, and sometimes also cultural and social constraints? Because virtual reality is like a dress that you need to craft literally around the needs of the patients, but you also need to understand, good, now we know who is the patient. We need to know what is the medical procedure, for example. What is the length of the medical procedure? What is the position of the medical position? What are the criticalities? And what is the context? So what are the specialists that are working in that moment? What they want? What are the needs of the nurses and physicians? Because something that we need to remember is when you deliver a solution in healthcare, you are providing this into a labyrinth of needs. There are many stakeholders there. If you provide a great solution for patients, but you are clashing somehow with the needs, with the routine of a nurse, probably your headset is going to end up on a shelf. So what you need is, you are not going to require more time from the nurse. You need to provide the solution in order to fit exactly in the workflow of nurse. You don't want to ask extra time, because nurses don't have extra time. We have a big problem in Italy also because we are lacking the number of nurses. So, well, it's a critical point. You want to inform them, so you need always to start with an entire day when you are educating nurses on how to use. And you need, especially in the first month, you need to be always there, always available to connect with nurses to answer specific question about how to use the device, because they are not going to catch everything the very first day. And in the next few weeks, you're going to explain a lot of stuff. So based on the need assessment, we craft the virtual reality experience following, first of all, best practices when it comes to user experience. So there are best practices to avoid cyber sickness, because this can be a problem, especially when we are working with people in oncology. You start with people who have some degree of nausea, and you want to reduce as much as possible any kind of cyber sickness. We start from the basics that you can use with any kind of user, but then we define visuals, sounds, and interactions that fit exactly at that intersection between the patients, the medical procedure, and who is delivering that. We want to make it as simple as possible. And after we crafted the content, of course, we provide it to the hospital. And what should be also curated is the narrative on how you provide the content to the patients. I want to make an example. We were working with some adult patients, and some nurses who not necessarily can be sensitive to the narrative, they say, hey, we are going to provide you this game that is going to be useful to manage you during the medical procedure. And we had this feedback from an old man. He said, I'm old enough, I'm not playing anymore. And this is a small point. Well, we had also a great woman, like she was 70 years old, and when he used the virtual reality, she said, oh, I am in the metaverse. And we said, yes, exactly, you're in the metaverse. And she was enjoying. So it really depends, but the narrative matters. And especially for adults, it's a relaxing experience that is going to simplify the treatment. It's not a game, because game can be, I would say not seen exactly as an added value, especially for adults. So yeah, virtual reality is an experience, it's not a pill. And the virtual reality intervention starts before and continues after. It's very important to curate the entire process.
Yeah, no, actually, you reminded me of some experiences that I had with users that had more than 55, 60 years. And more than top of my mind, I remember at least two that shared with me that they prized the opportunity to wear VR, because then they could tell their grandchildren that they had the experience both of the headset, and they could iterate a bit on that and generate a different kind of discussion. Yeah. Which is, again, another take. At the end, as you said, it all boils down to people. And
of course, this narrative will change in time, because the elder people of tomorrow will be people who, grew up with technology. and it will be completely different, providing this kind of technologies to them. So this is something that is very dynamic, and you should be very cultural sensitive and narrative sensitive when you are delivering an experience, a digital experience.
Perfect. I have a couple more questions, but meanwhile, for every participant listening, you are more than welcome to just place your questions also on the chat. Would love also to reel them in to Valentino. But meanwhile, Valentino, I understood from your presentation there are already some fields of application for VR for neuropain that are meaningful, let's say. So you started with oncology. You also see dentistry. My question is, I feel like there's a lot of research being done in this field, and I wanted to ask you, are you seeing research and are you seeing also results, market results happening on other areas besides these two?
Yeah, I think that, we are not lacking research like nobody. We have research starting from Hunter Hoffman. So really, and even before, we have decades of research. The big problem that I want to say, I shared before the example of RelieverX and the company in the US, in Los Angeles, it's Applied VR, great company. They really started more or less in the same period. 2016 was a golden moment for many companies entering the field. But the problem is this, if you go to the US, virtual reality has also code for reimbursement. They can be approved as a DTX. So that means that there is a business, I would say, framework when this kind of technology can enter. It's easier, not easy, but easier. If you are, for example, in Europe, we have mainly two kind of countries that allow you to potentially reimburse virtual reality content as a DTX. There are Germany and Belgium. Okay, and partially France. And then you have also UK. But for example, in Italy, this is not possible. So that means that in Italy, delivering this kind of solution is much, much more challenging. So we have a lot of research, but moving from research to product is challenging because you still lack this kind of framework. But side to this, another great application of virtual reality is for sure rehabilitation. Is an amazing tool for that. Because rehabilitation means that you can rehab or just provide continuity in rehabilitation wherever patients are at home in a world when we need delocalized care. But let's remember that virtual reality is also a sensor. So we can collect data remotely, we can track the advancement of the patients remotely, and we can provide timely feedback. So rehabilitation is amazing. Virtual reality can be used in hospices for vulnerable patients, in Parkinson and Alzheimer, because let's think, neurodegeneration is connected with the sensory, I would say, deprivation. Many elder people with Alzheimer, they risk at staying at home alone, not having sensory stimuli. You cannot stop Alzheimer, but you can slow down, and you slow down Alzheimer by sensory abundance. And virtual reality can be used in specific moments to provide selected controlled sensory abundance to these patients. Can be used for, I see also from the questions here, and thanks a lot, I see also Darlan Needs, she's using virtual reality inside the ICU to control pain and delirium. And this is one of the very interesting applications, because when patients are waking up, I would say in the ICU, one of the big problems is the delirium. And you need to onboard, or I would say reboard, patients back to reality. And virtual reality can be extremely useful also for that. So thanks a lot for citing this example. There are, well, of course, there is the entire field of cyber psychology. So using virtual reality for eating disorder treatment, using virtual reality with the PTSD treatment. This is something that Skip Rizzo is doing in Los Angeles, for example. Doing virtual reality, or maybe delivering virtual reality for autism treatment. This is a very borderline but growing area. I want to remember one thing. If I remember the name of the game, Luis, maybe you remember this. You remember this game in virtual reality that is very simple, white and red, and your enemies are red, and they are moving very slow. If you are moving faster, they start moving faster. I don't know if you remember this game. It's not Beat Saber, but it's quite also.
I don't remember the name.
Yeah. Anyway,
seeing it, yeah.
No, but it's one of the most
super hot, says Andrei Orlov.
Sorry?
Super hot.
Super hot, exactly. Thanks a lot, Andre. Super hot. I know the game designer of Super Hot. He's actually from Poland, and he has autism. And it's amazing because for him, creating Super Hot was an amazing tool to simplify reality on demand. Because one of the things, autism is a big spectrum, but one of the big problems is that people with autism, they perceive reality as too much complex. Let's simplify. And virtual reality gives them control to reduce the sensory stimulation, also to control the timing of everything. And in Super Hot, the fact that if you stop, reality stops, and if you move, reality moves, is exactly a way to cope with autism. He developed a game. Many people in the world, they are playing, they are excited, but for him was a little bit of a therapy, of self-therapy. And that's an amazing example.
Great. Not really, really interesting. Meanwhile, Rita shared a couple of questions here on the chat.
Yeah.
The first one regarding health economics evidence. Are you asking for these metrics when you start negotiating?
Of course, it's not always easy to find. Okay, this is exactly what we are doing right now with a multi-center study. We are trying to connect with the administration of the hospital to say how much this is costly today without virtual reality and how much you're going to save of time and cost. But there are so many stakeholders sometimes that it's quite difficult to track exactly the entire process. So you should have a hospital team that is very collaborative. Okay, it depends on the administration, it depends on the team. We are doing our best to collect this information, but I cannot, I would say, I should say that some hospitals they have a more open attitudes now to track this kind of data, others less, a little bit, because there is a lot of internal coordination. But this is fundamental, because if you want to justify this value, it's not only about the experience, but it should be economically also sustainable for the hospital and an advantage for the hospital.
Yeah, but it's always hard because it's it relates directly to data. Rita is also asking if your solution is software as a medical device, digital therapeutics, or none.
So it's not digital therapeutics, and it's actually not a medical device so far. For the specific kind of solution that we are delivering, we are not collecting data. We are not changing the way clinicians are working. We are not changing the decision-making process. And this is something that so far, we want to classify this as a medical device class 1. We have the data, we just need to start also the procedure of the medical device approval, certification, sorry. But so far, to distribute in the hospital for this specific activity and based on the claims that we are doing, it is not required. Of course, the more we gain also clinical evidence, the more we can get closer to a certification. But it can be marketed without a certification. If we are, for example, in the German market, it would be amazing to classify this as a digital therapeutics.
Yeah. And again, as you said, you are not collecting data.
No.
But that might be something further down the road. But actually, data is the core matter, the core subject of the work that you're doing with medical XRSI.
Yeah.
I'm maybe in the next couple of minutes, if you could just frame a bit more about what your work is regarding patients' data and the focus
for sure.
Because
regarding
I believe, yeah.
Back in 2016, when we connected with the first hospital, our goal was to use virtual reality also as a tracking system for clinicians, so that they can use virtual reality as a system to track how the performance of patients were changing in time. And this maybe could be also an opportunity not to identify potential issues. But we have been clearly said by the hospital, we don't want you to collect data because we don't want this complexity. We don't know exactly how to manage the cybersecurity complexity of this data, so we prefer not. So we decided consciously to not invest in market products that collect data, because it's not a feature, because there is a work behind, but it's not a feature that is valued by the hospital, but by our target hospital. We are collecting data in the research field, in the academic field. So we are working, for example, with Politecnico in Milan and many others. When we are showing different ways of quantifying stress, that can be extremely important. For example, in Politecnico in Milan, we showed that we can infer heart rate and respiratory rate just from the movements of the head resulting from the heartbeats. This is called ballistocardiography. And this is extremely useful to potentially unlock adaptability loops, like you quantify the stress and you adapt the virtual reality scenario to the specific needs of patients, because it's an experience that should be iterated to the very specific conditions of patients. So for us, it's an opportunity, but there is a gap between the opportunity and the implementation in the hospital. Once again, it depends on the hospital itself. So virtual reality is a great sensor. No, you can collect so much data. You can collect motor data, biometric data, you can infer biometric data. So we made many cases, Luis, the example of eye tracker. No, eye tracking in virtual reality can collect raw data about where you are looking for, where you're looking at. But from this information, we can potentially infer, like companies can infer your cognitive load, your neuro conditions. You can actually collect digital biomarkers. Digital biomarkers that can be informative, they can say something about your current condition, or also predictive. So this kind of information is extremely sensitive. And well, we need to have more transparency on exactly how this kind of data are collected, processed, and reused. For example, I know that some of the hospitals in London and UK, they don't want to use meta devices. Well, for many reasons, but because they are a little bit concerned about exactly the transparency of data flows. This kind of understanding is not so widespread in the hospital. So the work that should be done is to really explain to the hospital, remember that this is not just a smartphone on your eyes. This is a complex device that really provides a full body tracking of your information. And this information can have health value, but they can also be misused. Just to make a more, I would say, advanced example, full body tracking means that I can collect the pattern of your movement. And the pattern of your movement is a little bit your fingerprint. And this can be reused to create digital clones of you. It can be used for creating the fake version of yourself, not only in virtual reality, but also for other purposes. If you use an Apple Vision Pro and you scan your eyes can be potentially used to unlock devices or to unlock bank accounts. Just to say, there is a systemic kind of potential issues that should be considered. So transparency and trackability of how data are managed by these systems are fundamentals. And this starts with awareness and information of the first stakeholders that are not only patients, but clinicians. It's a wide topic, of course. I just try to touch different points, but the data part is full. And at the medical XRSI and XRSI-Europe, we are trying to simplify this complexity by creating data classification. The medical XRSI, they are doing a huge data classification effort in order to say, first of all, let's start with the basics. What are the data, how they can be collected, and how they can be misused? You start with this, and you, of course, inform policymakers to create potential laws that include this kind of understanding.
Yeah, and you have so much of it, right? You have so much data being collected, and you can also converge that data with other kind of data, and therefore, well, yeah, a lot to be taken in, and awareness on these topics is really, really important. And the fact that you're working on guidelines for hospitals and healthcare professionals to handle this more properly is absolutely
it's fundamental. And I see also the question here of Rita, how much time do you spend training the healthcare teams at the hospital? Well, we always say one day. We say we are completely available one day, all for you, for all of your questions. Some hospitals make value of the one day, some hospitals less because they have less time. So we had very diverse situations, like sometimes really, hey, we have only 1 hour and we need to run away. But we precisely just 1 week after we have the call, sorry, we don't know exactly how to switch on. So 1 day is for the document, 1 month is for reality, because we keep engaging with the hospital for 1 month after the installation. Is the most critical moment. After 1 month, Generally, you made clinicians autonomous in using VR. And after that, there is maybe just bug fixing, you know, some updates of the content, but the first month is always critical.
Valentino, yeah, that's ramping up a project, and onboarding is really core, especially as we are working with a different interface. So thanks for this. We're reaching the end of our time for this episode. Again, Valentino, thank you so much.
Thank you.
I would just ask you
the questions.
I would just ask you. Perfect. Wonderful. So I would just ask you for some final thoughts on the topic of our episode. And meanwhile, please to everyone out there, do stay connected. We are going to continue our Metaverse webinar series already next week. And meanwhile, Valentino, can you share a bit more also about again your overall vision for VR for Europe in the next couple of years?
Well, I really hope that we are going to have the possibility to create critical mass and critical thinking around all of these topics, okay, to have more opportunities to discuss this, making value of the great diversity of Europe, but also connecting and to operating as a one system. Okay, this is I think it's a one big challenge. And this is true at the same also when it comes to hospital. The big problem in the hospital is that every hospital address virtual reality in a separate way from the others. And the only way to advance this technology in the hospital is when all of the hospital will find consensus. What is the minimum standard for this technology, how it should be used, and how it should be validated. So we need exactly the same diversity, but also systemic approach to this technology. And hopefully we will have more opportunities to explore in this way VR, not only in healthcare, but in our citizen life.
Yeah. Let's strive for standards or a more standardized approach.
Exactly.
So that it eases up the adoption, at the same time also creates some rules that can enhance trust in our field. Again, Valentino, thank you so much.
Thanks a lot, Rich. Thanks a lot, everyone.
Thank you. Yeah, exactly.
And let's
everyone
connect.
for being here.